So thank you everybody for joining. This is Society of Thoracic Surgeons Adult Cardiac Surgery Database monthly webinar for October 4th, 2023. On the line with me today, we have a really nice group of panelists, some of our wonderful surgeon leaders, Dr. Dave Shahian, Dr. Guy Payon, Dr. Michael Bowdish, Dr. Miklos Kurtai. Dr. Robert Habib is the Vice President of the STS Research and Analytics Center. And then we also have Addie Dolan, Emily Conrad, Leanne Jones, and Melinda and myself on behalf of STS. We'll go through a couple STS updates. And then I'm going to hand it over to Dr. Shahian to talk about the beta blocker project that's coming very soon your way. Yeah, I'm on camera. I hope that's okay. I don't know if you want me on camera or not. Am I covering up any of the screen?
No, I was just saying, just in case you were
Oh,
aware.
yeah. Don't pick my teeth on camera. Okay. I won't. Thanks, Leanne. STS updates. October training manual was posted. Harvest 3 is to be released in mid-October. I think we're hoping that it will be out the second weekend in October, but we still have to do some testing on it. Once it's released, of course, we'll post notification on the IQVIA platform, and we'll send out email. I think we also have been doing that. AQO was awesome this year. It's some really wonderful presentations, very well thought out content that it was just, I was amazed at how in depth some of that education went, both on the clinical side and on the abstraction side. AQO 2024 will be in person. We have not been able to disclose the location yet, and hopefully we'll be able to do that soon. But mark it on your calendars because we're planning for September of 2024, early September, and it will be limited seating. So stay tuned for more information on that. Important to dates for Adult Cardiac. Today's the monthly webinar. October 18th is the Quality Improvement Series. We will be reviewing our current status with the prolonged ventilation and decreasing vent times improvement series. The data looks promising from what's coming in at Harvest 3. So just having our analytics center do a couple double takes on that, and then we're looking forward to presenting that information to you on October 18th. November 1st is our monthly webinar. November 10th, Harvest 4 closes. That's OR dates through September 30th. And then opt out for that is November 14th. And don't forget, if you do have any questions, be sure to put them in the Q&A. November 15th is the Quality Improvement Series webinar. I think I have somebody lined up on that one, but I have to check and see who it is and what they're presenting. There was a great presentation at AQO that won the poster presentation. I may be reaching out to that person to present on November 15th if we don't already have somebody lined up. Early December, we will be having our post-AQO Hot Topics webinar, and that is just similar to last year. Anybody who registered for the AQO sessions will have access to the Hot Topics webinar. We'll notify you with a link and all of that, and we'll bring back speakers or topics with our physician and data abstractor speakers to get more in detail with some of the questions we received in. So looking forward to that. The Harvest 2023 dates, just a reminder, November 10th is when Harvest 4 closes. That will be OR dates through September 30th. And you could probably expect that report, we're closed November, mid-November. I'm probably guessing in January with how I'm considering the various holidays that are within that time frame. So probably January for that report. Harvest 4 report, Harvest 3 report we should expect out in the next couple weeks. And now I'm going to hand it over to Dr. Dave Shahian from Mass General and Harvard Medical School. He's going to talk to us about a project that started in the Task Force on Quality Initiatives at STS and subsequently is now working with the Quality Metrics Task Force regarding beta blocker. So Dr. Shahian, I'm going to hand it over to you.
Great. Thanks so much, Carol. Well, we appreciate the opportunity to present to this group a topic that we've been working on for several years, but we haven't talked a lot about it because it's been It's been challenging, and we do not yet have the answers to the questions, but we have a lot of questions. And I hope that you will find this informative. Could I have the next slide, Carol? So most of you are aware that our STS cabbage composite has 4 domains, one of which is a medication domain, and that domain requires that you administer all 4 of the medications that are listed at the very bottom here: pre-op beta blockers, discharge aspirin, statins, and discharge beta blocker. The issue that's been debated considerably in the last 5 or 6 years in particular has been whether pre-op beta blockers belong in this medication domain. Could I have the next slide? Now, there's substantial reason to answer that question. Yes. In the original 2011 ACCAHA guidelines for cabbage, perioperative beta blocker recommendations included a class 1 recommendation for beta blockers administered at least 24 hours before cabbage to patients without contraindications, mainly to reduce the incidence or sequelae of postoperative AFib, to be reinstituted as soon as possible after cabbage, and to be given at the time of hospital discharge. A decade later, the 2021 ACCHA guidelines on the right-hand side of the slide had downgraded it slightly to a class 2A. So it says that it can be beneficial to reduce the incidence of postoperative AFib. I think that there's several reasons for the downgrading. One is that most of the randomized studies, actually all of the randomized studies that supported the class 1 recommendation are fairly dated at this point. And, you know, probably some of the papers that have dealt with the STS database and beta blockade may have also influenced that decision-making. Next slide, please. Important to know that this is also a continuing metric of the Centers for Medicare and Medicaid Services, CMS, endorsed by the National Quality Forum. It's NQF 0236. Of course, NQF is now transitioning to Patel, but it will still be endorsed under that until its next measure maintenance period. Next slide, please. It's also been extensively reviewed not too long ago with a generally positive finding in support of the evidence. Next slide, please. And the European guidelines, EACTS guidelines on perioperative medications and cardiac surgery also give it a class 2A recommendation, should be considered, level of evidence B. And they actually expand a little bit more in their discussion of beta blockers, and they make the point that patients who have had recent myocardial infarctions may have particular benefit from beta blockers before cabbage. And of course, at least in terms of non-ST segment MIs, this is a fairly common presentation for cabbage. Next slide, please. So pretty good evidence, I'd say very good evidence to support our inclusion of beta blockers in our composite measure. So what's the problem? Well, the problem is that a number of investigators, initially mostly from Dr. Mack's group in Texas, but also from Damien Lepar and his colleagues at Virginia, and then a few other studies and a meta-analysis by Wang, have shown either no association of preoperative beta blockade with postoperative outcomes. And in fact, the Wang and colleagues meta-analysis actually showed an increase in postoperative AFib rates in pooled data, which of course makes very little sense. Next slide. And several commentaries have been written about this. Dr. Hui and Dr. Lee have talked about the fact that this is probably a much more complex issue than the binary characterization that we currently are constrained to. And I've written another commentary on this issue, talking about, why from a physiologic and pharmacologic standpoint, this still makes sense, and some of the nuances. Next slide, please. So it's an ongoing issue. The US and EACTS guidelines still support preoperative beta blockade at a 2A level of evidence B level. Many of the original randomized trials are now dated. They're unlikely to ever be repeated because of lack of equipoise. There are several studies from our own database that raise questions about the efficacy of preoperative beta blockade, and in the Wang meta-analysis, really inexplicable increased risk of AF. But in that meta-analysis, they did not have amiodarone information available, which probably explains this. Some of the anti-beta blocker studies, in particular the Brinkman study and JAMA Internal Medicine, have excluded recent MI patients, and those actually are the patients who may benefit most from preoperative beta blockade. So I think it's important for all of you and also all our STS members to know that we have not ignored this contentious and very confusing issue. We've been working on this for years now, trying to figure out a way of addressing some of these inconsistencies. We've been doing it with a small working group of task force for quality improvement representatives, quality measurement task force, and the Society of Cardiovascular Anesthesiologists. Dr. Habib has gotten involved in the past year and has some very nice studies from the research center showing that there actually appear to be sort of three types of hospitals with respect to beta blockade and outcomes. One in which outcomes are better, one in which outcomes are a little worse, and one in which outcomes don't seem to be much different. Very, again, interesting, but hard to explain results. Next slide, please. So certainly patients and the conduct of cardiac surgery are different today than when the original RCTs were performed, and even in those randomized trials, there was great variation in the specific beta blocker used, the dose, timing of administration, and so forth. Amiodarone is used in many programs today as an alternative prophylactic agent for AFib. But overall, and we've talked to electrophysiologists about this, it's unlikely that there's been any underlying change in the pathophysiology and pharmacology of AFib and beta blockers. I think it's clear that our database does not currently collect sufficiently granular data to really look at this question in detail. It's also clear that programs vary substantially in how they give preoperative beta blockers. And I think some have a check the box mentality and just give a little squirt of something that's probably not going to have any beneficial effect. And also, many of these pre-op patients should already be on beta blockers. So how many beta blocker naive patients who not previously have been exposed are actually getting optimal titrated preoperative beta blockade? So last slide, please. So where do we go from here? We clearly need additional study, either a survey of actual practice or a registry randomized trial. We may need to update the database to include somewhat more granular beta blocker information. We may need to modify or more precisely specify the requirements to satisfy the medication domain within the cabbage bundle. But we've got to do anything we do with extreme caution and with good scientific basis. We don't want to convey the message that preoperative beta blockade is unwarranted or harmful, which is really inconsistent with current ACC/AHA and EACTS guidelines. So we think that a survey may help us to better characterize current practice. We clearly need to educate STS and SCA members regarding these ongoing efforts. We are really trying to figure this out. We're not ignoring the fact that there is conflicting evidence. And ultimately, I think we need a multi-societal quality improvement project to identify and incentivize the best practice use of preoperative beta blockade. So with that, I'd like to turn it over to two colleagues who have been working, been very influential in this whole project. Dr. Miklos Kertai from Vanderbilt is a cardiovascular anesthesiologist and is a representative on TQI of the Society of Cardiovascular Anesthesiologists. Has been extremely helpful and insightful, and obviously anesthesia is very much involved in the administration of these beta blockers in many instances. So he has been extraordinarily helpful in these efforts. And then Guy Payon is the chair of our Task Force on Quality Initiatives and has been leading these efforts for several years now, and has done a great job helping us to get down the path to some answers. So I'll turn it over to Miklos and Guy at this point.
Thank you, Dr. Shaheen, for this nice and kind introduction, and also providing such a detailed and excellent overview of the beta blocker topic. So this is just a quick review that how we would like to plan this study that is going to be a prospective survey information type of clinical study. Next slide, please. So in terms of the what, how, and how long this study is going to be conducted. So as I indicated, this is going to be a prospective survey-based study to really better understand and characterize some of our current and ongoing clinical practices in terms of the administration of perioperative beta blockers for the prevention of atrial fibrillation after coronary artery bypass grafting surgery. In terms of the participating sites, we wish to encourage all centers, almost 1,100 centers across the country, to participate and contribute with this valuable piece of information to really address some of those questions that Dr. Shaheen has reviewed in his presentation. So in terms of to help really with that additional data collection process and also trying to minimize any potential burden of how this additional information is going to be collected, with the help of Dr. Habib and his team, a complementary REDCap survey has been created, really come up with a minimum but necessary number of questions that could help us further understand and discern some of the practice patterns that could explain why there are differences in the rate of postoperative atrial fibrillation in patients who receive beta blockers across the different centers that participate and contribute with data to the adult cardiac surgery database. In terms of the duration of that data collection process, we discussed, and the plan is to run the data collection process for a period of 1 year, 12 months. There are many reasons why we feel it would be important to run the study for 12 months. Most importantly, some of the seasonal practice variations could be accounted for if we have a year worth of information in terms of beta blocker administration practices in patients undergoing coronary artery bypass grafting surgery. Next slide. And in terms of what are the expected outcomes, and Dr. Payon, feel free to weigh in too. So basically, we are hoping to achieve the following outcome goals, if you wish. One is to, as I indicated, to characterize the contemporary practice of therapeutic beta blocker administration and try to really better understand whether some of the practice variations are or could be the reasons for the observed differences in the rate of postoperative atrial fibrillation across the different centers that contribute to the adult cardiac surgery database. Subsequently, we also hope that this survey-based study will generate sufficient data for future measure reevaluation and approval, and more importantly, provide evidence for practice guidelines or the revision of those future guidelines in terms of what would be the best practice to follow in terms of using beta blockers for the prevention of postoperative atrial fibrillation after coronary artery bypass grafting surgery. Dr. Payon? Your mic is muted.
Yeah, sorry, thank you. I think, Dr. Sheehan presented the conundrum quite clearly, and you've outlined what our hopes are for this study. What we're trying to accomplish is to address those shortcomings in the data collection that we have that Dr. Sheehan alluded to. As he said, the preliminary look at the database that we've done with Dr. Habib's help through the Research Center indicates that the results related to beta blocker use with the data that we presently have in the database fall into three categories. There's a group who does better with beta blockers, there's a group who does worse, and there's a group that beta blockers don't seem to make a difference one way or the other. And it's hard to imagine that it's related to a specific patient response to the medication. And so we believe that it's related somehow to the administration practices at these various hospitals. And it really is no good way, given the variability of how the patients present currently with whether or not they're on beta blockers, and to be able to do a randomized trial. And so we're hoping that we can collect a small amount of data that's not duplicative of what's already in the database to give us additional information on exactly how, to the extent that we can, the practice of beta blocker administration varies from one center to another, and how that might interact with the results that we're seeing in the database. And we'll be able, hopefully, to also then include the potential interactions with the use of amiodarone. So I think, I don't know, are we planning to show a preliminary version of the data collection form today or not, but it's our intention to make it very, very simple and easy to collect the data and present it to us within the survey analysis.
Yeah, we do have a draft form available. First of all, thank you, Dr. Sheehan, Dr. Kurtai, and Dr. Payon for explaining the rationale of this project and going through what the expectations are, that it's voluntary, but we do encourage participation. It is for isolated CABG cases only, and it's important to better understand beta blocker administration practices at facilities and the related outcomes that you're seeing in the data to make a better practice guideline for physicians treating patients preoperatively and postoperatively with regards to AFib. Judy, I saw your question. I do have a draft of the form. I'm happy to share that. I just have to find it. Hold on. They're used to me, our attendees are used to me digging in my folder, so I don't feel bad about this because they know I have stuff everywhere on my computer. So hold on, I'm getting there.
But while you're looking for that, Carol,
Mhm.
Neither of the three of us mentioned the word voluntary, and I want to emphasize that this is in fact voluntary. Obviously, we would like for as many as possible to contribute. The more cases that we can accumulate over that 12-month period, the better it will make the opportunities to appropriately analyze the data and come up with a meaningful conclusion if we're able to do so. But it is, of course, completely voluntary for the data managers to collect the information.
Yeah,
So-
and knowing how important our data managers find their role in improving patient outcomes, I think that we would have a large number want to participate in this for their isolated cabbage procedures. So this is a draft form, and it's not final, it's still draft. And I just, we wrote it out this way just so it would mimic the current data collection form, but it is already, it will be built in a red cap form. So a little bit different layout, but very simple to use, very streamlined. Our research center team lead on this, her name is Nikki, and she does a great job at building these red cap forms. But this is just to help you if you wanted to fill it out on paper, we'd make something like this available. So you could write it down. So I just use the short names that we already have available: participant ID, patient ID. These are fields that will be already available in your software or direct data entry forms. Same thing with record ID and date of surgery. You would just use whatever you used on this field is what you'll just copy over here on. And then MedBeta and MedBeta Ther, these are the two fields that are collected in the preoperative medication section on the version 4.20 form. If you answered yes to either of those questions, then you would fill out, we have the type of medication using both the generic name and the brand name. So if these medications were given, you would mark which one was given. And then other, if it was a different one that's not listed. You'll see here medication given closest to skin incision start time. We're looking at the time that you documented for this field within the version 4.20 data collection form, which is this surgical skin incision start time. I just put the short name and sequence number for easy reference. So if you if you did give a medication, beta blocker medication, the type of medication, the dose that was given, and the route that was given, oral, IV, or unknown. And then the timing, was it given less than 1 hour prior to incision start time, between 1 to 2 hours, 2 to 8 hours, 8 to 16 hours, or 16 to 24 hours. And we're not considering incision, the incision time, as anything after skin incision start time is not considered preoperative. And then for the postoperative beta blocker administration, beta blocker administered between OR exit and discharge. So as you know, in the discharge medications, we are collecting if patients are going home on beta blockers. What we're not currently collecting in the database is the time frame from OR exit to discharge. So this is what that section is going to capture. If the patient was giving a beta blocker between OR exit and discharge, the type, name of beta blocker, dose, route, and then timing. 24 hours from OR exit, 24 to 48, 48 to 72, or greater than 72 hours post OR exit. And then the last question for that section, was the postoperative beta blocker administered as a result of new onset AFib after the OR? So this is just asking if you know if that beta blocker was administered as a result of new onset AFib. Yes, no, or unknown. We don't want you to guess. Just be as honest as possible. If you can find it, great. If you don't know and you're unable to find it in the chart why that beta blocker was given, sometimes they're just standing orders, and sometimes it's a result of something, and this is the treatment for that. If you're able to find it, great. If not, then code no, NA or unknown. And then for the amiodarone treatment, there's two options. We haven't decided which one yet. We're going to collect, or the method that we're going to use to collect this information. Hopefully they both get to the same thing. We're just asking the questions a little bit differently. Amiodarone starting prior to OR entry, yes. Prophylactically, yes. For treatment for AFib, yes. Prophylactically converted to treatment for onset of AFib, or no, not administered or unknown. Same thing between OR entry and OR exit, and OR exit to discharge as prophylactically for treatment of AFib or prophylactically converted to treatment for onset of AFib. And then the second option, we're deciding between the orange or the blue, which one is easier to capture for you all. Amiodarone initiation, where it was started, and the reason for administration. So we're picking out which one to go there. And then the last question is patient in AFib or aflutter on last documented rhythm strip prior to discharge. So this could be rhythm strip, EKG, any rhythm that you have charted on that patient. The last one prior to discharge, did it show AFib or aflutter? So that's where we're at with this. It will be coming soon. We don't have this built out yet. We're kind of tweaking it a little bit to make sure we're collecting the information in the most economical way possible to decrease as much burden. But we do hope that you all will consider please completing this and submitting the information in REDCap. It will only be for it's your isolated CABG patients, and it will provide a great benefit to the scientific side of better understanding beta blocker administration, and to make a good recommendation so we make sure we're treating patients with the best care that using the science that we have available. So hopefully you'll be able to be part of that. And I think I reviewed it all. Was there anything else you wanted me to go over, Dr. Payon or Dr. Kurtai, Dr. Sheehan?
No, I would say I think that was a good summary of the basic outline at the moment for the collection form. I will again stress that although it's voluntary, we obviously would like as many participants as possible. And in point of fact, once the form is finalized in its REDCap form, I didn't count the exact number, but I think it's only 6 or 7 questions when you add them all up at the end of the day, because there'll be drop downs. I assume that you really will only have to select one from each. And we believe that this will provide us, this set of data will provide us an opportunity to do a better job of trying to determine what properties of beta blocker or the administration of them may or may not be most important. And as Dr. Sheehan said, it's hard to just say at this point in time that we should no longer do this because we don't have evidence that's conclusive that they're not beneficial in the perioperative period.
Right, thank you. And one thing I would add, or just want to make sure everybody's aware that if you are able to collect this data for us for the SCS and to better understand patient care related to beta blocker use, we ask that you do it consistently on all of your patients. If you're not able to do it, then we hope that something changes and eventually you are, but just to be consistent, if you are going to collect it, please collect it on all of your isolated CABG patients. So we have a complete picture of the CABG population without making any biased judgments on the data collection side. So, and
Carol, it's Mike.
Yeah,
hi, Dr.
Bowdish
Bowdish.
has his hand raised there, Carol.
Hey guys,
Oh,
I've
sorry,
been
Dr. Bowdish. Sorry.
I've been ignored, which is fine. There's a couple good questions in the chat, but a couple key things. One, this is not a trial. So I know that the word trial was sort of mentioned in various presentations, but so it's not a clinical trial and it's being done for quality improvement. So you don't need consent, you don't need an IRB, you don't need to, we do not consider this a trial. This is being done for the same reasons that we collect all the data that we collect in the database. And that's a really, really important distinction, because obviously if it is a trial, that adds a whole different level of regulatory issues that we need to deal with. So I wanted to be clear about that. I think Carol will probably go through many of these things. The form is not publicly available quite yet because we're still working on it. And it won't be in your vendor software directly for a number of reasons. But that'd be a nice way to do it, but we can't do it that way right now. So And then
Yeah.
there's a bunch of sort of very specific questions about different drugs, which are all really great and things we may have to think about a little bit and get back to people a little bit on some of this, Carol. I think, oh, the other one that someone asked about was surgeons. And I think, we plan to message this to the surgeon community as well. I think as a surgeon myself, I think in general, people will be relatively happy with us doing this because I think there's a fair number of surgeons out there that are moderately skeptical of whether or not this is actually effective, because as Dr. Sheehan and Kurtai pointed out, if you just get if you get 5 milligrams of low pressure in the OR before you make a skin incision, does that really change your outcome? And that's one of the things we're hoping to be able to look at. So just like messaging to the data managers, we will message this to the surgeons, both likely with some editorial or commentary in our journals, as well as at our maybe we can figure out a way to message it at the STS as well.
Right.
So anyway, those were my only, just looking at some of the comments here.
Yeah, we're going to go through these here. Thank you, Dr. Bowdish.
But the
Wonderful
trial one's a
comments.
big one. This is not a trial. If anyone disagrees with me, please disagree with me. But we do not want to consider this a clinical trial. We're just doing this for quality improvement.
That's right. It's a quality improvement initiative. Similar to all the other variables we're already collecting in the database. We just need more granular information on these variables, and for a short amount of time, not the whole length of this data version. So, and Hannah Whitney, you have a couple great comments. Hannah is one of our colleagues at North Shore in Illinois. The real question is, if patients haven't been on beta blockers, do you start right before surgery? If they are on, yes, it's been proven to be beneficial. And then similarly to the AMI CMS beta blocker metric was withdrawn, is there any consideration to stop these until we can prove it better? Anybody want to make a comment on that? I think we stopped. Dr. Sheehan covered this in his talk and said, it's still a high level recommendation that we need to continue. We'll collect this data for a year and then make hopefully make a better recommendation, or better understand the current recommendation. So let me get those. And then will the beta blocker survey be available in our vendor software? It will not. It will be a standalone REDCap form. The link will be available in the training manual, and we'll do more education on it as we get closer to going live with it, to make sure everybody knows where it's all at and how the form works. What's the optimal patient volume for facilities who participate? Dr. Payon, did you want to take that one?
Yeah, I would say that obviously the more patients that you can enter, the better for the study overall over the course of the full year. But I think to go back to Carol's statement, it's probably more important that you consistently enter all of your patients, whether it's a big number or a small number, rather than having a large number but only entering a portion of them, because that builds in a variability in and of itself.
Okay.
And so I think it's really more the completeness of participation rather than the absolute number.
And I would add that I think it's actually valuable to have participation of programs of many different sizes,
Yeah.
small programs, large programs, medium size. Perhaps there's some association between the way beta blockers are administered in small versus large programs. I don't know. But I think having as wide a distribution of programs as possible would be the way to go. And in fact, we specifically avoided another option, which would be to sort of select programs that we thought would be particularly interesting to study. We'd like this to be as comprehensive and random as possible.
Great.
I agree
Thank you.
with that, Carol. If I may add
Yes.
one more thing to that. So by providing and having information from small, intermediate, and large volume centers would give us the opportunity to generalize our findings and adjust and account for the variability that Dr. Payon and Shaheen and Bowdish indicated. So this is really the only way we can have this really unbiased approach in terms of understanding some of these practice variations. So consistent data collection and data entry from even a smaller center or a low volume center would be as valuable as having information from a large volume center.
Wonderful. Thank you, Dr. Kurtai, Payon, and Dr. Shahian. What's the intended start date to enter the beta blocker information into the REDCap form? I don't know that we have a date yet. We're hoping within the next, I think in November sometime, November, December. We just have to finalize the form, which is almost done, and then build it in REDCap. But it will be coming within the next couple months, and we will be providing more education on this and also including these fields within the training manual. So more
And
to
if
come.
I can add to that, the reason we are really glad to have the opportunity to present this topic to all of you on this webinar, because we are also interested in your questions and feedback to how to really finalize that data collection form. And really, as Dr. Shaheen and Bowdish and Payon indicated, reach out to the surgeons in terms of messaging this information too. So nobody is going to try to avoid anybody taken by surprise if this is ready to roll out. So really in the next months or two, we want to make sure that we can finalize the REDCap data collection form, provide the necessary level of messaging, and then subsequently, if we all feel comfortable rolling this out, hopefully then in the next months or two, we should be able and ready to do that.
Thank you, Dr. Kurtai. Dr. Bowdish?
I was just going to say, it's really fantastic. I mean, there's 434 people on this call. And so one concern we've had is we want to do this, we need people to participate. And we realize it's a little, not a little, it's extra. I mean, it's extra work. I don't know, how it's extra work for all of you. And so we've gotten questions here from people who it seems like people are supportive of the idea and in general willing to do this. I think that if there are people on the call who feel otherwise, you don't have to send us nasty emails, but it would be nice to hear if there are people that really think that this really wouldn't be something they could do in their site. That's information we'd like to hear too, because we'd like to hear what you think the barriers might be to doing this. We're trying to make it really easy and simple. But that's been one of our concerns. If we do all this and we only get, a real handful of centers to do this, then the results become less generalizable. So I'm not asking for unpleasant email, or on Carol's behalf, but
our data managers are great.
Yeah, but if there are people out there that are less, skeptical, please let us know, because we want to try to get it right and get good information. So
yeah, and thank you.
Let me just add to stress the point that Dr. Bowdish made about this not being a study. I think that's a very important one worth restating. What we're asking is really not for you to change your treatment process or your algorithm for AFib or prophylaxis in any way, but just to report to us several additional questions regarding what that process is, and that's important for you to understand, but also, as several have indicated in their questions, and in presenting this to their surgeons, which we will also do, as has been stated, in a number of different approaches over the coming weeks. But that it's not a study. It's not something that needs IRB approval. We're not asking to compare different treatment algorithms. We're just asking for you to record what you do in taking care of your patients and providing us with that information. And I suspect some of you, have electronic health records that you might be familiar with, that this might only take a few minutes for you to figure out what dose was administered at what time. And others, perhaps with different systems, it might take a little bit longer. But whatever we can do, as Dr. Bowdish said, in terms of your feedback to simplify the process, would also be welcome.
Great. Thank you. We have 10 minutes left, but we have 47 questions, so hopefully we can all stay on just a little bit longer to see if we can get through some of these. I turned on the upvoting on the questions, so if you could please just upvote your favorite questions, I'll read those first. Could facilities participate on a quarterly schedule? For example, data manager might have more time to complete during one harvest over the other, therefore would be able to complete all for isolated cabbages within a harvest, but not another. Would that be okay?
Well, I think it'd be great if you, it'd be great if you're going to participate, you participate. In that, I think one methodological error would be if we just get a smattering, say you do 100 cabbages, we only get data for 20, that becomes a little bit hard to deal with. So if you're going to participate, we really would like you to participate. If you choose to just sort of give us all the data with a harvest every 3 months or every, I don't think that's a real problem. We won't, in talking to Robert, we talked about this a little bit. We'll basically pull the data out after a couple harvests to look at the completeness. So I think, when you get it in there is not, it doesn't have to be exactly contemporaneous with your upload of your main form, but to me, it's probably going to be easiest just to, if you're going to do it at the same time. Otherwise, it might be a little bit extra work, but that's up to you guys. I don't know if that answers.
Yeah, I think that's good. And I think one of the other suggestions I would have on that is, I would just, I mean, you're going into the MAR anyway. I would just pull it from the MAR right on paper. And if you have time, then, keep those paper data collection forms to the side for the beta, more granular information on beta blockers. And then, when you do have time, go into the red cap form and just fill all of them in. I mean, I think
Yeah,
that would probably be more a process from a process standpoint. I think that would probably be more better use of everybody's.
Yeah, and unfortunately
time.
on the red cap form, you have to enter a couple identifying features so we can link the red cap form with the STS form. So
Yeah.
It would seem to me it would be easiest to probably do it all at in the same setting. But you may all develop different processes, but
Yeah, find what works for you. Okay, the highest voted questions is how I'm going to do this. Do you have a summary of this presentation that we can share with our surgeons in consideration of participation? This video recording will be available. It is an hour long, and your surgeons probably won't want to sit through this, but they may. It will be available by next week on our YouTube channel. But I think there is planned communications that will be going out to the surgeons separately from this, explaining the project and the intended extra additional data capture. Is that correct, physician friends?
Well, I'm not sure who's supposed to
yes.
answer that, but I don't know what we haven't gotten to the exact process, but the answer, as Mike said so eloquently, is yes.
Okay, thank you.
We don't have the details, but yeah, we should message this in our STS, messaging, and there's obviously other creative ways we can try to message this to the surgeon community. I would also say though, knowing a lot of your data managers, you guys are also the eyes and ears, and so please, some of the messaging can probably come from you guys as well, but we do need to give you the tools to do that. So
Great. If for post-op beta blocker, if a dose is ordered but parameters not met, do we have options of contraindicated or simply yes given or no not given? So Cindy, this is going to go to the 2 parent fields I mentioned on that data collection for med beta and med beta ther. If those are captured as contraindicated, then you do not need to fill out the post-op, the pre-op granular medication information on the red cap form. And I think that we'll have to look into that, and maybe because that patient may have post-op beta blockers. So we probably have to review that and how we're going to handle if one or the other or both are captured as contraindicated. So thanks for bringing that up. The only barrier I can think of is if we are required to garner additional BAA to use this. Our compliance department may not support data entry into REDCap. There's no additional business associates agreement. This is part of the data collection for the STS, and any vendor, it's listed in your agreements. Any vendor that we used for data capture is part of that BAA that we have. So I can review it with you, Susie, if you want to send me an email. Maybe I'm missing something on that. Has consideration been given to those patients? Oh, and here's the other one, David Grix from Michigan, MST CVS. Consideration to those patients with beta blocker contraindications, an emergent or emergent salvage status. So I think we can review that as well with the surgeons. It's probably more of a discussion than something we can talk about online right now. But I'll put it on the list for our next call. Often my patient will get both an oral beta blocker within 24 hours and IV esmolol prior to incision. Would we capture both?
It's a good question. I would say probably for simplicity, capture whichever one is the first one, the 20 with, not the closest to the incision, but the initial dose.
Okay.
Is
We'll
what
have
I
to make
would think, and I'll ask if Miklos, David, and Michael agree with that. But
Agreed.
yeah, Carol, there's a question about centers that use outside contract abstractors. I wouldn't know how to answer that, but regarding whether or not they have to renegotiate the contract with the vendor.
No, hold on one. No, they shouldn't have to. I'll get to that question in just, I don't know where it's at. Hold on.
It's, yeah, I don't know how to number it. It's from a Beth Canale.
Oh, okay. Beth.
351.
Let's see here. We got lots of questions. So we have 60 now. We went from 47 to 60. We use outside abstractors. So I'm assuming a company like Qcentrics who performs outside abstraction, we have to pay for extra data collection, and then we would have to enter REDCap ourselves. This isn't so simple as if you abstract on your own. Yeah, that's something that I guess we'll need to consider about that, Beth, and maybe I can talk more to you about that to better understand. So we can come back with a recommendation from the group on how best to do that. And maybe I can also talk to some of our friends at Qcentrics to see what that would mean for them. So thanks for bringing that up, and I'm happy to bring it back, discuss, and then talk to you and our Qcentrics folks about it. And if you use a different third-party abstractor company, let me know. You have my email address, and Leanne Jones will put it in the email in the chat box for everybody. Who initiates the desire to be involved in this study? Is it our lead surgeon or the data abstractor? And I think Dr. Bowdish touched on this a bit. Dr. Bowdish, you had mentioned something about the data managers being our voices for the surgeons to explain this and encourage participation. What are your thoughts on who
Well,
should be?
I think every center is going to be a little different. We know there are some centers where surgeons are pretty involved in data entry, and they'll want to say, hey, we want to do this. And I think we'd like to see that. I think there could also, what I was alluding to is I think the data managers could also say, we want to do this. The reality is, I think many surgeons likely don't know what all is being entered. So I have a hard time believing that a surgeon would be unwilling to at least conceptually have these extra 10, 15 fields uploaded into the system. But I think you all know the dynamics at your sites, and you may have to we may have to think about that a little bit, Carol. I didn't, I don't know what Guy or Dave or Nikos, what do you guys feel about that? I hadn't really thought about that.
It's hard for me to imagine that, our colleagues are going to be in some way against this. It's no, I mean, the truth is, it's no extra work for us. It's extra work for our data managers. And if they're enthusiastic, I would suspect that there's no harm, no foul for the surgeon. One of the other issues that's interesting to think about is how to get the cardiac anesthesiologists involved in some fashion. And Miklos, you'd know more about this, because there's only about 60 or 60 or 70 anesthesia programs that submit to the database out of the 1100. So some other mechanism of involving them so they could potentially figure out a way with their data managers to make whatever medicines they're giving readily available in some fashion within their electronic health record if it's not there already, so they spend less time searching around for it. But as far as we surgeons go, as I said, I agree with you. I don't know why any of us would object to our data managers just more clearly presenting what we do.
I mean, I think many, I'm going to admit I'm a little biased, but I do practice. I mean, I practice in a large academic center, but I also do practice at a few community hospitals. And every hospital, there's a point person for the relationship between the database and the data managers. And so I would encourage as data managers, I would encourage you to reach out to that point person. And if you're in a center where there really isn't one, then maybe talk to Carol and ask, let's be a little bit, maybe there's some other creative way to do this. But I do think getting that point person you have as your surgeon sort of liaison is probably the, a good approach to making this happen. And that's how I kind of think how we would do this at our 5 different places that would do this. But it's a good point. And we definitely don't want to upset our surgical colleagues. We don't want to upset the data managers. We want people to be on board with doing this. And hopefully, as Guy said, I find it really hard to believe that someone's going to get upset about this. The people I've talked to, that I've had several surgeons say, it's about time you're going to do this. So I think the reaction will be exactly the opposite, but maybe we're wrong.
Melinda, you have your hand up.
Well, yeah, I was reading through all these questions. I think there's a big confusion about what the REDCap is exactly. I think people think it's a separate vendor or something, and I think you need to just explain the REDCap. We've been using that for valves for quite some time now.
Yeah, for a couple of years. Dr. Kurtai, I think you're pretty familiar with REDCap. I think it lives at Vanderbilt or originated at Vanderbilt. So do you want to talk a little bit about what REDCap is?
Yeah, absolutely. And Carol, also feel free to weigh in. So this is basically an electronic application that can, in a systematic and organized way, to create, in our case, for instance, the survey type of questionnaires, and subsequently using a link, collect that information, organize that information, that subsequently that information can be linked with another data set that could be uploaded into the REDCap application, and really can help us to sort of link the STS adult cardiac surgery data with this additional piece of information, and subsequently analyze these practice patterns. So it's not another vendor. This is not something that any center would have to pay money for. This is basically available without any charge. So it's free of charge, and this is basically a scientifically accepted and proven way of using that application for purposes such as the survey-based study we are proposing to perform as part of this initiative. Carol?
Yeah, there's a few questions in here about certification, the security on the REDCap platform, and I think we could probably provide more information on that. the RedCap platform is a secure platform and they do have the proper security in place. Our RedCap expert is not on the phone with us, Nikki. She is unfortunately out sick this week, but we will get more information on that and follow up in a subsequent webinar. Now there's another question. Thank you, Dr. Kurtai. There's another question here regarding adding the link to the RedCap, adding the RedCap link to the vendor software. We can certainly check with the vendors on that, but I don't know, I'm not sure how that works. The link is going to be right in the training manual, and then you can copy and paste it onto your desktop for easy access. And we can go through all of that on another webinar. I can show you all those shortcuts to help make it easier. It still means that you have to go out of your vendor software to enter the data, but it flows pretty nicely. It's just a link that's sitting on your desktop as an icon. So we can talk more about that.
Carol, could you also mention potentially some of the few recent examples when the same application was used to collect any additional data that was needed, some of the ongoing studies within the STS Adult Cardiac Surgery Database Initiative?
Yeah, so we're using the RedCap form right now to allow entry of the valves that are not, the devices that are not available on the device list for valve implantation. So we had a couple valves that were approved after the current version went live that were not included in the drop down on the vendor software. So sites are going over to that RedCap form to enter in that device. And let me show you, I don't know if this is helpful or not, but let me show you one question if I can put my, let me pull up my Google, move my questions out of the way. My mouse is going in and out, sorry, one sec. Okay. And I'll just a quick of what it similar to what it will be like for on this beta blocker project. And this is sts.org. I'm just going to the data manager section, going into adult cardiac, accessing the data collection resources and version 4.2. The link is just embedded within the training manual. And when I try to find it, I just search for RedCap.
I also have a link, a bookmark for it too. I guess I'm curious how many people on the call are actually entering their valve information in the RedCap with all these comments.
So this is the form for, this is just under the valve implant number. This is the link to the RedCap survey, and it just takes you right to RedCap, right to the STS. And this is just the information you would enter. As you enter it, you just hit next. It would be pretty simple. It's pretty simple to do. And you can find more information out about RedCap by clicking this Powered by RedCap form. Gives you all the information if you need more. It is safe. It's supported by NIH. So it's a great platform to use for these types of projects, and it's free. So, okay, let me go back over to questions here. Yeah, you could save it to as a single link, and it's easy to get to. If they increase beta block, here's a clinical question. If they increase the beta blocker dose to treat new AFib, do we capture that or just a new beta blocker given post-op for AFib? I think it was any beta blocker given. And then we asked the reason, was it if it was administered as a result of new onset AFib? But the consideration that they may have been on one and that the dose was increased post-operatively might be something our surgeons and anesthesiologists can weigh in on for us. physician friends?
Carol, this
I
is
have to
something.
unmute. Yeah, I'm trying to find my mute button. Go ahead, Nicholas.
Go ahead, Guy. You started first, so go.
No, I was gonna say, I think, you know, assuming that it's the onset of postoperative atrial fibrillation, you know, if they were on a dose of beta blocker, I would record that dose as the postoperative dose, and not the one that you increase it to after they're in atrial fibrillation. And
Yeah, I
again,
agree
ask
with
if-
you,
if,
Guy.
Nicholas and Mike, I know Dave had to leave, but if they agree with that, because what we're interested in is what they're on before AFib. Frankly, a little bit more than what they're on after AFib.
That is correct. We really want to know whether giving beta blockers or restarting beta blockers immediately after surgery or within a reasonable time frame can help to reduce the risk for atrial fibrillation. This is not the information we want to know in terms of how much extra was prescribed after an onset of a postoperative atrial fibrillation, because often cumulative doses of the medication of the beta blocker is given. So it would make the data collection process even more complex or cumbersome. So we're really not interested in capturing that information, but Mike and Dave, feel free to weigh into.
I think you may, are they still on with us? I think they may have hopped off.
I know Dave has hopped off. I know I can't see that part of the,
Oh, Dr.
Dr.
Bowdish had to go
Yeah,
as
Dr.
well.
Badish had to hop off.
I had to go also, okay.
Yeah. I think they agree with you, Dr. Kurtai.
Yeah.
That was that.
Great, thank you.
You're welcome, anytime. Let me see. So one question, and I think we're probably going to have another webinar. We now have 76 questions waiting for answers or comments. So I can try to get through as much in the next 5 minutes if you all can hang on with me for 5 more minutes, if you don't mind, Dr. Payon and Dr. Kurtai. But I think our plan will be maybe to revisit this in the November monthly webinar as well to
Yeah,
bring
that'd
back
be
some of
fine,
these
right? I can
questions.
stay for a
Okay.
few more minutes and then also.
Yeah,
Okay.
me
We can
too.
certainly try and be
Okay.
available on the next call, Carol. So-
And then
Okay.
I would be happy to participate on the next call too.
Okay, thank you. So to clarify, with the red cap survey, we would only fill out if a patient received beta blocker within 24 hours. So no, this is collecting, it's collecting specific time. So if the beta patient did receive beta blocker within 24 hours, then we want you to get a little bit more granular with when it was given. And here are the time frames listed: 1 to 2 hours, 2 to 8, 8 to 16, 16 to 24. Second part of the question is also, we at times have medrecs that state beta blocker was given, for example, 10/4/23 in the AM. We would need a timing option that states unknown. So we can add that in. That's a great point. Will it matter if the patient's med change or the dosage? I think we talked about that. Dr. Kurtai, you had said the dose that was originally ordered, correct?
Yes,
and that
just
increased.
to keep it simple, changing in the medication dose is probably would go above and beyond in terms of the granularity of the information and complexity we would want to capture on this data collection form.
Okay, and then I think you already covered this one. It says, so does it matter? So it does not matter if they received a one-time dose of beta blocker versus on maintenance therapy pre-op. We have patients that will be on it routinely, but then still get a small dose right before incision, which would be the one that we would capture, but not be able to capture the routine therapy at all. So the routine therapy would be if they're on a beta blocker 2 weeks prior to surgery. That's on the regular data collection form. It's the med beta equal to yes, as if the patient was on beta blockers 2 weeks prior to surgery. And then the next question is if that patient received beta blocker within 24 hours. which is this med beta thera. And if they did receive either of these, was also a dose given prior to incision start time? And what was the dose given prior to incision start time? I hope that I think I answered that. Anything to add on that?
No, it sounds perfect to me. I hope this was, an answer which was well received, but if there are still questions about that, I'm happy to address those either today or during the next webinar.
Okay, thank you. This is from Hannah, may need to give more time to one, convince our teams that this is a good idea and provide certifications of red cap security. So I think we can do the red cap security thing pretty easy. Dr. Kurtai looks like he's getting ready to go back into the
Sorry.
OR. No problem. Totally support this. Worth a little extra work to answer this important question. Getting data on dose, route, timing, previously on beta blocker is easy. Getting dose, route on DC beta blocker is easy. We can say yes or no to a new AFib easy. So it sounds like that's good feedback for us. And oh, hold on. What did I do here? My question skipped down to the bottom. Thank you, Beth, for that comment. Could the draft form be provided? So I can certainly provide the draft form. We can, if you want the form, please email me, ccrone@sts.org. And I think Leanne put it in the chat box. If not, maybe Leanne will put it in the chat box. Just email me and I'm happy to share the draft form with you all, if that's okay, with our colleague, with Dr. Payon and Dr. Kurtai. That's not a problem on my end. Are we going to try to start for calendar year? Every time a new question comes in, it resets it for me. Oopsie. Are we going to try to start for calendar year 24 as an easy way to track patients starting January through December 2024? And that's a comment that maybe we can take back for you, Dr. Payon and Dr. Kurtai, to consider the start date on that.
Yeah, I think, as Carol said earlier, we'd like to start as early as possible. And so we're hoping to get it started by end of November or December, although it may be the better part of valor actually to bypass the holidays and start January 1st. I think we'll sort through that as we try to work putting together the final version of the collection form, and with feedback from all of you as to whether you need more time to figure out how to do it and all of that. So I don't think we've made that decision yet.
Thank
I
you.
absolutely agree with that. It's really, seeking feedback from all of you, as well as making sure that we are going to be able to message this to our surgical colleagues as well as the cardiac anesthesia colleagues. So in that way, we are not in a rush. We really want to make sure that we have the best and most available support. So if we have to start in January, we are fine to start in January. In terms of data collection and data analysis, it doesn't really matter whether we start in November or January, because it's going to be a 12 months process of collecting that information. So it doesn't have to follow kind of the calendar or the fiscal year in terms of considering rolling this study out.
Thank you. And just one more question. I'll let you both go and then I'll answer what I can answer for the next 10 minutes. And then we'll regroup with this conversation in November. I can't believe I'm saying November. But one more question here from Karen McNichol. AFib, oops. This thing drives me crazy. I don't know. And I start reading. AFib type and timing history is important behind rhythm and entry to OR. Current STS definition. Will that be included in the collection or study? So I think
Carol, correct me if I'm wrong, but I think that we capture what the preoperative rhythm is in the database right now. And
Correct.
And so the red cap form is intentionally being created so that you don't have to answer the same question twice. So if the patient's on AFib preoperatively, that'll be known in the database and treated accordingly as we do the analysis. In terms of, the effect of beta blocker on the incidence of new AFib, obviously that patient wouldn't count as new AFib.
Thank you. Thank you, Dr. Payon. All right, I'll let you both, if you need to go, feel free to go. I'm just going to answer a few more questions that I can answer, just to clear up any
Everyone, thank you, Carol.
confusion.
Yeah, thanks everyone for this. I can't believe there's so many people on this call. Thank you, Carol.
Yeah,
Everyone.
yeah, thank
Thank
you so
you.
much. It's a
Bye.
great group. Thank
Yeah.
you. Thank
Bye.
you so much. Folks, if you want to stay on, I'm just going to go through a few more questions here. Melinda, you can stay on or leave if you want to. I just don't want to leave all these questions out there. How will we get the data to you if it will not be available through our vendors? It will be in the REDCap form, and then we'll download from REDCap and link it with the, let me show you that form real quick here. Hold on. We will link it. Can you all see my screen? We'll link it with using these identifiers, the participant ID, record ID, patient ID, and date of surgery. So we'll be able to link it that way from the REDCap. We download a whole big Excel spreadsheet and then do it. Okay. Oops. I'm gonna go back. Let me see. To increase abstraction time and reduce calculation errors, perhaps we could simply enter the specific time beta blocker was given pre-op, and formula could calculate time frame. The incision start time is already obtained in the regular abstraction. That's a great suggestion, Molly. I think folks do it differently. I'll bring this back to the surgeons. I don't think the surgeons realized or the physicians realized how easy it was to get times out of the MAR. And I agree with you. I think just what medication was given, the timing of it. And if you all feel that way, let me know if you think that that's easier than answering these questions this way with the timing and having to do the calculation. Just providing, re-entering the surgical incision or the OR entry, and then the time of beta blocker dose and what it was, and the dose route would be fine if that's all something you think would be easier to collect. What if amio is given for rhythm other than AFib, aflutter? So this is specific. We might have to revisit this one. Yeah, we might have to revisit this one. So unknown, that's a good question, Molly. We're going to have to revisit it with the physicians when they come back in November prior to this. It's a little extra work, but for those sites using outside abstractors, they will probably want to renegotiate their contract. I certainly hope not, but let me see if I can talk to some people at the third-party abstraction companies to discuss this with them.
Yeah, Carol, I'll be able to help you with that too.
Okay, thanks, Melinda. This study would be more feasible if the data could be entered directly into the vendor software versus a separate form. Yeah, unfortunately, we don't have a software, a version upgrade scheduled at this time. Version upgrades are typically 2 years in the making. And this is something that we need to get the answer to pretty quickly. I know a year seems like a long time, but it's a lot less shorter than 3 years, timing a version upgrade just for these few questions that don't need to always be abstracted. And then all the whole vendor certification, new release, education, and anything else they try to throw in during an upgrade that happens. So right now, this is the most realistic way to get the data, not the easiest. If it's something that we need to capture long-term, we'll definitely include it in an upgrade, which is not planned at this time. This would be great information to know as we are always looking at our beta blocker amiodarone AFib rates with facility data to improve our practice. Thanks for that information, Jenny. When we come back with the surgeons in November, or if you want to send me an email, I can find out from our REDCap administrator if that is something we can provide per request by facility ID. But I don't think we're collecting PID on the form, but if it's something we need to add, we can add it and see if it's something we can make available since we're collecting it. Yeah, we'll need some good supporting documentation, well written and detailed to present to our teams. And I think the best way to present this to your team, simple format, it would be STS is asking that we collect more granular beta blocker administration information. Here's the rationale for collecting it. And we will start collecting it on this date. Not more information besides that. I mean, these are just additional fields. It's like with anytime we make a change to our versions, we just make the change. We don't have to provide information, granular information as to why we are getting more granular or less granular. But I certainly understand that it would be helpful in getting buy-in at your site. Also include anesthesiologists in the message to inform that. Yes, absolutely, Natalia. A potential barrier for our sites is the use of third-party vendors. So we'll find out more about that from some third-party vendors that we have contacts with. So Sherry, if you could just let me know, are you not submitting new valve data to the the valves that are not on the drop-down list? Are you not submitting those? Or have you not had any to the REDCap form? Never knew we were supposed to be entering into REDCap for valves. Yes, it's been in the training manual for quite a while. And we educated on it on the webinars. And we sent out emails. This actually started in July of 2022. So just over, or I think, or September of July 2022. It's been in the training manual since July of 2022, and we educated on it and sent out emails. So it's in there. Well, these webinars are great for us as abstractors and data managers. Having this information in a written modality to share, utilize when proposing this to our teams would be greatly appreciated. Understand, Erica, we have to start somewhere. So we present it on a webinar, so emails with information don't go unnoticed, and so that you're looking for them. And then once we have that information written, we'll be able to share it. I think the physicians also needed to hear from you all that they need something in writing to bring to their teams. So that's very helpful to share with them. Would it be the same REDCap link as the valve data entry? It'll be a different REDCap link that goes right to the specific survey, Jenny. So this REDCap link, you'll see this ID number here. This is to the valve survey. The REDCap link for the beta blocker will be a different one. So you just save it right next to your next to your valve link. Judy, your question is more for the surgeons regarding heart failure, evidence, beta blockers, and other beta blockers. Should we separate out the metoprolols? I'm going to leave that question. The surgeons are going to need to answer it. If you are able to join in November, please do, because I think that's an important one. Same thing, Suzanne, with your question regarding amiodarone at pre-op for other arrhythmias. I don't want to answer that question inaccurately. I'll review these with the surgeon. I print out all of these questions and review them with the surgeons. It's a big issue because this is in the STAR rating. And once there is money involved, this puts too much pressure on the programs to comply. I'm sorry, Hannah, I don't know what that's what it is referring to.
I think it's referring to the pre-op beta blocker metric. And I think that's
Yeah,
what
I
she's
mean,
referring to.
Oh, okay. Well, I think Dr. Shahan covered that in his presentation about there's still evidence and there's still a high level of recommendation that continues. So we are going to continue with that recommendation in our metric until we have something to prove otherwise. So we need to better understand it. And it's like he said, it's not just beta blockers. It could be related to beta blocker timing, beta blocker dose, and types of beta blockers. So we need to understand that better to make an improved, if needed, recommendation. I'm sorry if I missed this. Will it be in IQVIA automatically? It will not. It will be just on the RedCap link, not in IQVIA. So the RedCap link is what you'll need. It will be difficult to get why questions. The expectation is that all cabbage get a beta blocker pre and post up now. We only push them to provide why for those not getting it. I think you're talking about why was the medication given? You should be able to find this in the chart though. I mean, if the patient goes into AFib postoperatively, that should be somewhere within the chart as the reason for ordering the amiodarone. I think that's what you're talking about, Beth. If not, let me know, and we can discuss it more with the surgeons on the next call. Why do we email, or can you set up a quick poll? I don't know what that means, Tina.
I think that
Oh,
was in
you're,
reference to how many people.
oh, that's a good
would be willing-
idea.
Yeah.
That's a good idea. That actually is a great idea, Tina. Hold on. Let me launch one here. I think I have the yes or no questions right in here. Okay. So I'm going to launch this. This just says risk A and B. For those of you who, and I'm assuming that the next 300 people or 217 still left on this call are going to answer yes. But for those who do want a copy of the draft collection form, choose option A. For those who do not, don't answer, or choose option B. And I'm going to keep reading questions while I let that run. It's would cases that are emergent be included as well? And yeah, I think we're planning to collect this on all isolated cabbage cases. I may have missed it, but will the review include a look at the patients on chronic pre-op beta blockers too? We'll have that information in this field med beta, Kim. So we will use the participant, patient record, and date of surgery to do med beta, to include that as well, which is the chronic or greater than 2 weeks medication. And somebody asked about, I think Jenny Anderson, that was you, about providing sites that information for their facility. I forgot, we do collect the PID, the participant ID. So it is something we could do. I just have to talk and figure out if it's something that we're able to operationalize with staff here. I'm sure surgeons would be glad for us to participate. Looking forward to getting this started. This has been a great hot topic. Agree, Sue. Thank you so much for that feedback. We are actually in the process of updating pre-op beta blocker orders. Would not take effect for a couple months and would likely change or data mid-year long collection. Is this okay? I think you need to do what's right for your site and for the patients, Erica. I'm not sure if I'm understanding the question correctly. The slides are posted with every presentation on the website, Karen. When you go to, let me pull it up if I can find my thing here. On the data manager page, under adult cardiac webinars, you'll see the previous webinars, and then right down here, sorry if that's covering, hold on, right down here, you'll see the view slides from the previous webinars. To pull them up. And then the recordings are right here. So they will be available. Can you post the answers, email responses about the third-party abstractor also, so we also use one? My response was that we need to check with our third-party abstractors or get more information. That's really between you and your abstraction company. Is we don't negotiate anything, but I would like to talk to them or maybe explain the project to them if they have questions, because we don't want folks to have to pay more money to get this data. STS registry is using IQVIA system. Is that not enough? IQVIA is no, I'm not sure I understand, Crystal. IQVIA is our data warehouse. So your data is submitted from your third-party abstraction company, which is either usually a software vendor. We do have the direct data entry into IQVIA for sites that had signed up to that. Those are sites who do not use third-party abstraction company. I don't know where the question went.
Carol, maybe I can help explain this a little bit better. I don't know if I can or not, but you guys need to think of this as just like, so, we have temporary fields in the database right now. We don't have enough temporary fields to ask these questions in temporary fields. So in order to get these questions answered, much like the valve red cap that we already have, we are creating a red cap to get the questions answered. We can't do an upgrade right now. An upgrade, as Carol said, takes 2 years. It's 2 years long to even first a year to plan it, and the second year to actually get it done. So the information is needed we need the information in a more timely fashion than waiting for 3 years, which it would take if we did an upgrade and incorporated all these questions into the database. So I don't know if that helps or not, or if it just muddies the water, but perhaps it does help.
No, you know what, Melinda? I totally forgot that was that's what we needed to say. If we still had temporary fields in the adult cardiac database, as most of you are aware, we're using those temporary fields to continue to collect COVID information. If we were no longer collecting that information, we would put these fields right into the data collection form using the temporary fields. We don't have any temporary fields available because of that. So we have to go over to the RedCap platform. Thanks, Melinda. I totally forgot about that. Was the whole reason why we were doing RedCap.
You're welcome. I'm just trying to help.
Yeah, as always. And Beth saying there are no patient identifiers entered into RedCap. It's patient ID, not MRN. Right. Patient ID is something that is assigned by your vendor software or direct data entry. It is not a patient identifier. It's not PHI. It's not anything that we need to be concerned about with HIPAA. It's a number like when you go to the deli counter and you get number 45. It's like that. Like this patient is 45. And so we use that to link, use that non-identified number to link the cases within the STS database and the RedCap form. Thank you, Beth, for that information. I think yes, I would rather provide incision time and dosage instead of calculating the time frame myself. Okay, thank you, Jen. I think we're going to have to end here because the questions just keep coming in. And I don't think we could keep on staying on the line. I have to go catch a train.
Well,
How are you doing?
I think the other thing, Carol, was we don't have anything written down as far as data definitions or intents for these fields. So all of your feedback is really helpful to help us do that, because we need to do that. And so I think that's a real important thing, is some of these questions we can't answer until we actually sit down and get those things written out and talk to the surgeons about it. But all the questions you've asked today have helped us to realize that we need to do this, and your questions are very valuable. So thank you.
Thank you. Thanks, Melinda. And yeah, I think I've been using the word project. Thanks, Melinda. Hannah made a good point. She said, be very careful using the word study. It's not a study, it's a QI project. And the physicians might not realize when they use the word study that it comes across to us is something that does need IRB approval. This is not a study. This is additional information used for a QI project, which does not require IRB approval. And it's just like participating in the database. We're just getting more granular information. Same thing with if we were collecting, collecting this information within using our temporary fields, which unfortunately we don't have any more available. And it would be so much easier if we did. But thanks, Melinda, and thanks everybody for your input. I think we're going to have to end here. I didn't realize we were going to. Yeah, Brian says we use REDCap for everything. It's free to any nonprofit organization. It is a quality initiative. When it's finalized and the results come in, will it be published? Depending on what those results are, I think if they are useful to the entire community and for patients, it will likely be published. Are we supposed to be using REDCap currently? Yes, for the valves that are not available in the drop downs to enter in those valves. It's in the training manual. It's not simple to just enter. You need to have a STS number to enter your 5-digit PID number, which either starts with a 1 or a 3. After entered into your vendor and get number. Yeah, it's in your vendor software. That's why I said it's. I know somebody said they haven't used paper in over 10 years, but if you this form is pretty simple on paper, and I think just personally, if it was me and for process, I would just be filling these out as I'm going along. You're already in the MAR. Just notate this down right on the paper form. Keep a stack of them, and when you have time, go into the REDCap form and enter them into the REDCap link and enter them. I think it would be so much easier that way, instead of going back and forth between vendor software, REDCap, vendor software, REDCap, MAR, vendor software, MAR, REDCap. But that's just me and my process, my crazy mind. But we don't have a date yet for when it will begin. We do large valve volume. This will only be on isolated cabbages. We use REDCap. It seems like Melinda, it seems like people aren't using the REDCap for valves.
Well, that's why I was curious as to how many people are actually using it, and maybe we can ask that question on another call, just a quick polling question, because as I was reading through these questions, I'm like, wait a minute, there's a disconnect here. So maybe we need to revisit the REDCap and just explain it a little more and people understand it. And I think if you guys think of this as temporary fields, because that's really what it is, then you can wrap your head around it a little better. I know it's a pain to have to go to another place to do it. I get that. But as Carol said, and I think like her in the workflow, I would probably just jot this down on a scratch piece of paper as I'm going through. And so I'm not having to go back and collect all that data when I actually get to the REDCap form. So however works best for you, but that would be that'd be the way I'd do it.
Grace hasn't used the REDCap at all. Maybe you haven't needed it, but I hope you guys know it's there. All right. Times would be easier, definitely easier to enter time given. No, we can't build, unfortunately, we can't build these into the registry as they are. We don't have any more temporary fields. That was Crystal's question. Yeah, there is a question regarding rhythm at OR entry if the patient was in AFib, but I don't think there's a question on specifically what was the patient's rhythm at time of OR entry. We do collect history on rhythms like sinus brady, sinus tach, right?
That's correct. I think the key here is that we know if the patient was at AFib on OR entry, which is really part of what this is aimed at. So I think the surgeons are only concerned if the patient's in AFib or flutter fib when they enter the OR.
Okay. And then Kim said, can the form be posted on the web page where the slides will be? I just want to send it to those who want it, Kim, and those who attended the call. So I'll post it there. Let me talk to the surgeons about adding it as a PDF onto the back of the slides. But those slides won't be available until next week. So, all right. I think we gotta end, Melinda. I have to go catch my train before I miss my next call at home. I'm sorry,
Yep.
everybody, if we couldn't get to your questions. I wish we could keep going.
Yeah, I'm just not sure we have the answers to all these yet, because you and I need to work with the surgeons to get something written down about definitions and intent and things of that nature. Because I have questions myself.
I hear, yeah, me too. And I'm like, oh yeah, I don't see contraindication. That's a good point. I mean, Melinda and I are pretty thoughtful, but that's why we like your input as well.
So,
Okay. I'm not going to update the form before the draft is sent out because I don't have time. But we'll have a final form for our November webinar.
and you guys also look, if you're looking at this form, let us know if you like option 1 or 2 for amiodarone. I kind of voted for option 1 just because I thought it provided a little more granulation. But you guys let us know which one you like. So
Yeah. Okay. All right. Thanks, everybody. Thanks, Melinda.